So I'd like to take this opportunity to introduce James Spies, our 17th Tegtmeyer invited lecturer. Let's see if this advances. Not working, so you may actually have to use this thing to advance. Page down.
The old keyboard trick.
There we go. Okay. For those of you that don't know Dr. Tegtmeyer, he was the head of IR here. He really got what we call the Angio Interventional and Special Procedures Division going in 1973. Fritz came to train with him in 1991. I came in 1991 to join him. His nickname was Tunk. We always wondered where that name came from, but I think he said my parents thought I looked like a tunk. They called me Tunk. He's really known for developing renal angioplasty and renal angioplastic technology at a time that we didn't have covered stents and things like that, but we weren't doing a lot of lysis, so that if you ruptured a renal artery, we always had to have an OR at standby, so the patient can go to the OR. He was a serious person about delivering great patient care. He felt important that connecting with the technologists and created a school of technology that's now celebrated its 50th anniversary in 2023. He often said, I hate being Superman and always bailing you guys out. So anyway, he loved to fish. And every once in a while, there was a fishing tournament on the Rivanna Reservoir. And Fritz and I could be there working. There'd be 20 cases left to do. And he'd walk by and he'd go, looks like you guys got everything under control. I'm going to go fish in the tournament. And so Fritz and I would stay there and do. But he loved to fish. He, in fact, sold fishing equipment out of his basement. And there's, he also loved Diet Dr. Pepper. That's why we serve it here, Amy. And that's why I was drinking Punk's honor. And when they stopped allowing smoking to occur anywhere on campus in a building, it didn't matter to him. He still smoked his pipe in his office. And he used it as a tactic during negotiations to first fill the room up full of smoke. About 10 minutes before the meeting started, everybody would come in and everybody's eyes would be watering. And he would just torture them till they got them to the point where they said yes. And he was always drinking a Diet Coke. Unfortunately, he passed away at the age of 56, a very young age, as a post-operative complication. Now I'd like to take time to introduce James Spies. There's some synergy with Jim and Dr. Tegtmeyer. Jim likes to fly fish. He grew up in Northern California in Danville. He graduated from UC Davis with a degree in winemaking. Seriously. After graduating from college, he went to work in Madera, California, where he oversaw the production of wine for a year, and then eventually got accepted to medical school at Georgetown. Georgetown was not inexpensive, so he went the military route, and you can see him here after medical school and after training. He did some time in the military, 5 years working there. He was elected to AOA at Georgetown and eventually did his residency at UC San Francisco, where he's also chief resident. He went to New York at NYU and did a vascular interventional fellowship. And after working 5 years in the Air Force, he went to work in a high-end private practice in Pasadena, California. And I'm talking very high-level practice. His colleague was a guy by the name of Bill Bradley, who many of you know was really developing MR. And many of us would go to his practice to learn MRI from Bill Bradley in Pasadena in private practice before Bill went back into academics and before Jim went back into academics. In 1997, he left private practice and went to Georgetown and was appointed chair there in 2005. Here he is with his wife. To his right and our left is his wife, Vivian Fraga, who's an OBGYN that he talked about bailing him out on one of the procedures. And those are his two daughters that are pictured with Jim. He's considered a thought leader and internationally recognized for the work he's done with uterine artery embolization to treat women with symptomatic uterine fibroids. He was a national PI in a US registry that really led to data that got payers to pay for the procedure. He's authored more than 150 manuscripts. I would say probably 2/3 of them have to deal with UAE, and uterine embolization, all the aspects of that procedure. He's given more than 400 invited lectureships and more than 25 visiting professorships. He's an oral board examiner, and for those trainees here, you should know that he's the associate executive director of the ABR, overseeing the IR component of the oral exam. So he coordinates all that. He recently received the Distinguished Alumni Award about 8 years ago from UC San Francisco, which, as you know, is one of the premier training programs in the country. And Jim received that Alumni Award. He's a past president of FSIR, a gold medalist from the Society of Interventional Radiology. He also received the Leaders in Intervention Award from the FSIR Foundation. So he's a very distinguished person. More importantly, he's a friend. It's interesting how our lives have overlapped. I wanted to get in Davis. I couldn't get in there, and that's where he went to medical school. There's a picture of him. I thought I had it in here somewhere. Maybe it's right here to the lower left. With he and his,
talk about
yeah, he and his buddies went swimming on the Stanislaus River, which is a river on the way to Yosemite. And I used to go swimming in that same river because we grew up not too far apart from each other. It turns out we grew up about an hour and a half from each other. And then his wife, who's here, Vivian, before he met Jim, happened to deliver our oldest daughter. And so I think we were just meant to connect down the road. There were so many inner linking of our fabric that brought us together. So I'd like to bring on Jim, and he will talk about challenges in radiology practice now and in the future. Thank you, Jim.
Wow, can you all hear me? Yeah. Alan, thank you. First of all, I knew Tegtmeyer, and he was really one of the giants of this field. You know, when you work with him day to day, you don't really realize the impact that someone has. But he really was a founding interventional radiologist. Probably about no more than a dozen, maybe it's only 8 or 10 people that really were foundational in this specialty, and he definitely was one of them. He also built a great section, which has had subsequent fabulous leaders. And, you know, now you have two giants in Alan and Fritz here. And so just to put this in perspective, I've spent most of the last 2 days being jealous of you guys because you have a great group, great team, great residents, and really great facility. In fact, to be honest with you, I've been visiting Professor a lot of places, and your IR facility is better than most. So when you think about complaining at all about, well, why don't we have this and why don't we, you already have more than anybody else, so stop complaining. That's all I just want to say. So, some of this, I mean, we all sort of know some of this, sort of maybe just intuitively, you sort of know that things are changing in radiology, and I thought it would be useful, and I've given this a variation of this talk in a couple of other places to just talk a little bit about radiology, and specifically radiology workforce, sort of now and in the future. So I don't have any commercial relationships to disclose. I am the Associate Executive Director for IR for the American Board of Radiology, which is a part-time paid position. But it has nothing to do with this. I would be happy at the end if anyone has any specific questions about the boards to answer any of them as long as I can talk. But I'm not. Some things, you know, I'm not going to tell you the answers. All right. So we're going to talk about manpower in today's world, changes in practice models, which is a really key thing that I think is important for all trainees to understand. Recruiting, as everyone knows, is difficult in the current practice environment. Specialists versus generalists and what that actually means, and where we are going with that, and then sort of meeting the challenges of IR practice, because I had to put some IR in there. So this is just my perspective, and so I think most of you already sort of know this, but I just want to put some numbers behind it over the next few minutes. So there's been a massive consolidation in radiology practice, both by health systems and corporate purchase. The job market is very tight currently for hiring, particularly in diagnostic radiology. It is for IR, and it actually is in many medical specialties. And one of the reasons for that is that we have now more medical schools than we've ever had. We have actually more medical graduates, particularly if you count DO schools. There's just a ton of DO schools out there, but we have a really tight pipeline for residency positions. And so the number of people that are not matching into regular residencies or into fields they want to go in is getting more and more. And in our specialty, we can't graduate enough people to meet the demand. And that actually is likely to continue for the next couple of decades, despite AI. And I'm not going to talk about AI, but anybody in the room that's worried about AI, I wouldn't worry about AI. AI is going to be your friend, because otherwise you're going to drown in studies and not be able to get them all done. So there's a great flux of radiologists in the market, people moving around everywhere. Graduates want to practice in their subspecialty area, which is understandable. Graduates of diagnostic programs often don't want to do minor procedures or major procedures or any procedures. And really, general radiologists are the Swiss Army knife of DR, but they don't get the respect they deserve, particularly somebody in a practice that did not do a fellowship. And there are not that many of them around anymore. But when you think about them, you have to understand that they can do things that you can't do despite your subspecialty training. And this is just the general trends here in workforce. This is from the commission study in 2019 by the ACR. And it just shows, not that much in the way of change over here by the different types: private practice, academic, university, hospital, et cetera. But underneath this, there really is a lot of churn that's going on. So what are the big trends to think about? Well, there are fewer but larger radiology groups and more multi-specialty groups. So if one looks at this study, in 2014, about 31,000 radiologists in the United States. There are now 36,000. So we've actually had a 17% increase in the number of radiologists. Multi-specialty practices with radiology has also gone up. So I'm part of a multi-specialty practice. It's actually a health system, but we have 3,500 providers, all specialties, one professional services organization. But radiology only practices, the classic private practice or large groups that cover multiple hospitals, there were 3,100. There are only 2,100 now. That's a 30% decrease. So there are fewer radiology practices, but more multi-specialty practices that include radiologists. Well, why is that? Because they got taken over by somebody. And the drivers are health system consolidation with an enforced, maybe a little strong, or maybe you could say coerce, but if you're going to be working there, you're going to be part of the system. That's basically, it's an offer you can't refuse oftentimes. And there is a lot of market pressure from corporate consolidation in radiology, which I'm going to talk about. So if you look at this and say, what's happened over the course between 2014 and 2013, if you look at radiology only practices, this is the average number of the blue is the average number of radiologists in the practice. So it went from 8 to 14. So what happened? Well, the 2-man groups and the 4-person groups merged into an 8 or 10 or 12-person group. And so you have even small groups. I mean, a small practice, unless you are running your own imaging center and that's all you do, it is almost inevitable that you're going to be merged into a larger group because you can't really survive. And with the way contracting goes for insurance and other things, you really can get left out pretty quickly. If you look at the number of radiologists in the average multi-specialty practice, you can see it's 162 people here, but it's 21. So all of these things show radiologists going up in these alternate settings. So these are variations of the multi-specialty practices. These are majority radiology practices. And so you basically go from 21 to 46, a little bit of change here and a little change here, but all practice types in general, you're seeing more radiologists in one practice. So one of the trends is that, there are a few small practices. And when we came out of training, there were lots of 1 and 2, 4-person. I mean, people would have a whole hospital contract with 3 radiologists or 4 radiologists in a small rural hospital. And that's less and less the case. There are a ton of new practice models. So you have health system consolidation. So you have academic-based ones, and then you have not-for-profit systems. I actually work for MedStar Health. I'm the chair of radiology at Georgetown, but Georgetown does not own Georgetown University does not own the hospital. I have an academic appointment at Georgetown, and I run all the academics for them. But really, I'm an employee of a not-for-profit, a regional not-for-profit. And then, of course, there are for-profit hospital systems as well. Many of the multi-hospital systems like I belong to are actually run by the medical center. So you have UVA Health, or a huge one, UPMC. You have UPMC, I don't know, they have 46 hospitals or something. They have over 400 radiologists working for them. Half of the state of Pennsylvania is covered by UPMC. So these systems have all consolidated. The hospitals have consolidated. The radiologists that worked with them had to be consolidated. And so that's what's happening in a very broad way. And then you have physician practice consolidation, which I already talked about. You have individual practices saying, hey, we better get together because we're going to get smothered. And then you have the multi-specialty mergers, single specialty coalitions. And then the big thing, which is new in the past decade, is private equity practice purchase. Basically, all these models are intended to be able to negotiate better with payers. So if you think about it, well, where did those radiologists that used to be in radiology practices only, where did they end up after they merged? So in other words, they changed into some new model, and where did they end up? So if you look over here, in previous groups with only 2 people, many of them ended up in radiology-only practices. So they became, instead of being a 2-person group, they became a 4-person group or an 8-person group, or they joined something. If you look at the somewhat bigger ones, you see more of a mix. And this is where you get a group of 20 people that get merged into a group of 100 people. Or maybe it's a hospital-based system that has 300 physicians. So there's more in that way. But as the bigger it gets, you can see in general, that the more you have these large multi-specialty conglomerates in which radiology really is a minority share of this. So what does this actually mean? It means that radiologists have sort of lost control of their destiny. It used to be that they would be able to determine on their own, all right, I'm going to put in a new imaging center, I'm going to do this and do that. Now it's becoming a negotiation with the health system or with your multi-specialty group as to what new resources. And most specifically and importantly for me, they decide how many people you can hire. So I used to 10 years ago be able to say, I think I need somebody else. I had to get the okay of the hospital, but we had the reserves and the money, so they would just check it off. It was almost like a rubber stamp. But now it's a negotiation and it's a discussion, and it's more of an issue now because of the current volumes growing rapidly as they are for everyone. It's not a very difficult, it's just a more cumbersome way to go. So what about private equity? Well, I never knew what private equity was. And so my daughter actually works for Goldman Sachs and had to sit down and explain it to me a few years back, because I was like, well, what the heck is all this about? So if you think about it, it's basically just an investment class where a management firm uses pooled funds from investors to acquire companies that are not publicly listed. So basically, you get a bunch of people together, you say, I'm going to set up this private equity firm. You get a bunch of people to put in hundreds of millions of dollars, and suddenly you have $1 billion or $2 billion, and you're going to go out and buy stuff. So it's very similar to venture capital that way. But venture capital uses this model to invest in new high-risk companies, startups, right? And we all know about venture capital and whether you got the next Facebook or whatever. Private equity firms tend to acquire established, profitable businesses. So these are businesses that already have a net positive revenue, and so they're just basically making money. However, they're in a fragmented or inefficient market. And there's nothing that sort of exemplifies a fragmented or an inefficient market more than healthcare. I mean, healthcare is kind of a mess. Now it's, according to private equity, maybe less of a mess now because there's more of them and less of the fragmentation. But this is where they work. So they already know if they purchase these things, they can say that this group spins off a 10% rate of return or 12% or 15% or whatever else, and they can do the math and figure it out. And then they make a bet on that consolidation that they're going to be able to get economies of scale, get more efficiency, and therefore increase profitability to generate a return on investment. With the goal ultimately to be a short or midterm sale. So typically 3 to 5 years, a private equity firm wants to sell whatever they buy. These are not liquid. You don't go on the stock market and invest in a private equity thing. They're basically are high risk, relatively speaking, and they are illiquid. So therefore, they demand a higher return on investment from investors. And they typically would not even consider investing unless they think they can get 15 or 20% or even more out of investment. And so that part's okay. You understand that's capitalism, et cetera. But when it hits radiology, it actually can be quite jarring. So the primary business model in healthcare is to buy small and medium-sized practices and consolidate them into a single platform, and with the idea of increasing productivity. And if you think about it, okay, you have 6 or 7 groups, you bring them together, you put in a uniform packs, you put in a uniform building, you have a smaller but more efficient back office. You could see how that could be actually more economically efficient, and that actually would make a lot of sense. So you have the potential benefits of economies of scale, you have greater bargaining power in the market, you have capital investments for technology, equipment, and operations, which many groups do not have. And it is a real benefit to practice partners, because when they come in and buy, there usually is a very large initial purchase payment to all, let's just say, senior leaders within it. Now, every private practice is different. I was in a private practice years ago that when I started, I was led to believe that I would be a partner in 7 years. It was only about the 5th year that I actually was told that actually, there are 4 entities, and you're only going to be a partner in the first entity in the first 7 years, and then it's going to take you 4 years for this one and 6 years for that one. It's going to take 17 years to become a full partner. So there's a lot of different structures out there, some of which are not all transparent and easy to understand. But let's just say you have something in which you have full partners after 5 years in this private entity. All the senior partners might get a really big payment, a couple of $1 million, or who knows how much money, from a private equity firm. So it looks extremely attractive, particularly to old geezers like me, because I'm like saying, well, I'm not going to work that much longer. And boy, this is a great payout, and I'll just glide in. And what they're offering, or what they're demanding in return, is that you have to stay on for a certain interval as an employee, and you have to stay on in an employment model in which you're paid what they're going to pay you. And many times that may be less than what you're currently being made, but you can do the math. I just got a big payout. I don't really care how much money I make, and so it's fine. But if you're 35 or 38 or 40 and you're lower on the income stream, you actually could end up losing long term. So it benefits the partners, and they get a job continuation, etc. The downsides of all this are loss of physician control. I mean, basically, you're an employee, and they're not really shy about that. There is an inevitable requirement to increase productivity. I mean, efficiency means increased productivity. Now, if that means the billing's going to be better and more efficient, that's great. But if they say, well, instead of reading 30 CTs, we want you to read 40 or 50, because that's what we think a person ought to be able to read, you're in a kind of a tough spot. They can have very strict restrictive covenants, like really broad. So if you're going to be involved in a group, or you're in a group and they're going to be taken over by private equity, get a lawyer and look at everything, including all the fine text. Younger partners and employed physicians usually get little or no initial benefit, and often will have reduced income long term. So I have had over the years a number of people who have come to me and said, geez, I'm looking for a job. Well, why is that? Well, my group's about to be taken over, and it's not my interest, and I'm getting out. So one of the reasons we have all this churn is that people start to look at this thing from their own perspective and find out that it isn't necessarily great. There are documented high rates of work-related stress and burnout in this kind of a model. So where are we with this? Well, this is the number of private equity deals in radiology between 2013 and 2023. Now, it peaked in here, but you can see that there were 151 private equity acquisitions identified by this study. And there was at least one acquisition in 33 states in the District of Columbia. So in 2023, 12% of all radiologists in the United States were employed by private equity versus 1% in 2013. That is a huge increase. Now, it's still a minority, but it's a huge increase. In 2023, private equity had acquired practice that were in 3,463 locations, meaning like outpatient offices or hospitals or whatever else. That's 16% of all radiology sites. So they are gaining, each of these, and there are several large ones, are gaining power in the market. And so that, particularly in some geographic markets. So if you look at this, at that same time, 2 years ago, the percentage of all radiologists that were in private equity practice was 47% in Nevada, 44% in Arizona, 29%, you can see Texas. I would have guessed Florida to be higher, because every time I talk to any radiologist in Florida, they're like, yeah, private equity is buying up everything. But some other states even more. So this is, half of the radiologists in Nevada. That really is pretty impressive. So I'll just tell you my own experience with consolidation is not a private equity story, thank God. But when I took, well, I've been at Georgetown for a very long time, but in 2014, MedStar decided that they were going to go through a process of consolidation and imaging. So we had 9 hospitals served by 7 radiology practices, including 2 academic practices. So we contracted out to the University of Maryland to cover 2 hospitals in Baltimore. We have 4 hospitals in Baltimore. We have 2 hospitals in DC. We have 1 in Montgomery County, Maryland, and then we have 2 that are in Southern Maryland. So, and 1 which is in Leonardtown, which is about 110 miles away from Washington, DC. It's way down on the western shore of the Chesapeake, down at the very tip. By 2021, we had 9 hospitals with a single radiology practice. 7 went to 1. We had 115 radiologists. Now it's grown to, I don't think we have about 160 right now. And we can, I mean, I just got approval, I have 3 more radiologists for a semi-Nighthawk service. So we continue to grow. So what was the mechanism here? Well, we merged my academic group, which is the largest of the groups, and the other large group, which was at Washington Hospital Center. And they fired all the other groups, essentially. So, and part of that was quality related. They said, you know, we have issues with quality. The main driver behind this was there was great variability in the quality of the reads. There were lots of concerns. And some of those groups had really big outpatient presence. So there was a whole thing going on of where they potentially were steering patients to outpatient centers and not to the hospital, et cetera, et cetera. And of course, Maryland has very strange laws when it comes to outpatient imaging. The long and the short of it was they said, yeah, we're better off without that. We'd rather have our own employed physicians, but we can monitor the quality and be sure we're getting what we really are paying for. So we had a very cordial relationship with University of Maryland, and they were not, you know, poor providers, but they're also a competitor in the space. So we compete with Hopkins, Maryland, GW, MedStar is us, and then Kaiser, which we don't really compete with. So when you're doing a consolidation, you align all your team on one side, and you don't allow the other team with their nose under the tent. So that was a very amicable breakup. In fact, we hired some of those radiologists, but we had to go out and hire, I don't know, it ended up being around 50 or 60 radiologists over the course of a year and a half. I think we hired 35 in 1 year. That was, of course, back in the days when you actually could hire that many radiologists. I don't think I could hire 35 radiologists today. I'm not sure that I could hire 10 radiologists in a given year. We'd have to see. So what were the benefits of this? Uniform compensation based on national benchmarks. So this actually was very good for us because it used to be I ran a business. I mean, basically, you know, we had a certain number of radiologists who did all this clinical work, money came in, money from medical school, this and that. You do a budget, you figure it out, and you have a comp plan and you pay people, and then you have money hopefully left over at the end of the year. You put some in reserves, and then you pay a bonus at the end. And then you do the same thing the following year. Well, it turned out with this new model that we could not operate profitably across this system. And the reason is that they wanted an internal Nighthawk service, which is very expensive. And volumes at night are not that high. And so the bottom line with this whole thing is that we had a structural deficit, and we continue to have a structural deficit. But in a way, it's just something the hospitals have to accept. So what the health system is okay, in order to pay these radiologists the right amount of money, which we are nationally benchmarked and all this, we're gonna need X amount of money more than they actually bring in. So they divvied that up between all the hospitals. So the hospitals actually have to pay a tax to the health system to pay for us, essentially. But it does give us stability and compensation, and it gives us a model that we can understand. It also puts a burden on us to be sure that we're productive. And it's not an onerous burden. So we have uniform compensation. We have equitable distribution of bonus. We actually have a very transparent compensation system. Really, no one is paid any more than anybody else. And there's none of the sort of inequity you might hear about in other circumstances. We have absolute job security. There is no way that they're going to fire all of us and hire, you know, a private equity group to take over. It's just never going to happen. And we have really great IT support, and we have a single system PACS, which is excellent. The downside, well, as I just explained earlier, if I want to hire somebody, it used to be, you know, I could do it in an afternoon, make the decision, let's go for it. Now it's probably a month-long process, and depending upon where we are with the budget, it might be a 2-month-long process in order to get approval. Greater responsibility to meet all of their needs. So if you get someone saying, well, we need a breast imager out here, we have to figure out how to get a breast imager to be able to work in that place, however we can do it. With, you know, and this is true of all our subspecialty areas. IR is another big problem. You try to manage IR over 9 hospitals, some of which are very small hospitals that don't have a high volume. And you get a call and sort of suddenly, oh, you gotta run out and spend half an afternoon, 4 hours to be able to do one procedure because they don't have anybody to do it. So these are all issues you deal with. And of course, we don't have equity ownership. We don't, we're not building a business of our own. But in today's climate, I'd take this over almost any other model, particularly over private equity, because at least the health system is actually interested in providing good quality care, and they are willing to support, valid arguments in that direction. And the same thing would be true with this system, which is essentially the same, except this is run from an academic center. So your system would be very similar, I would think. Okay, so talking about the mobility in the workforce. So trends in radiology, and this is just a summary from this article, and they had a large number of radiologists that they looked at. 41% of radiologists separated from at least one practice in this 5-year interval. And there was a increased presence across all these different sites. The bottom line with this is that this is new and distinct. This is something that just did not happen when we came out of training, or even 20 years ago. It was much more stable. So the workforce is highly and increasingly mobile. So factors that influence departures, well, if you were early career, you had actually a odds ratio of about 1.3, or late career. And both of those are pretty almost intuitive, that, well, you get into a job, you really don't like it that much, or you decide that, you want to move back where your parents are or whatever. But people do make changes in the first few years of the practice quite commonly. And it's so common now. It used to be kind of like, well, what was wrong with you? Why did you leave the other practice? It's so common now that question doesn't get asked quite as much. It is less likely when you're a member of a large practice size, if you're in a radiology only practice, if you're in an academic practice, and for some reason the subspecialization of abdominal imaging, MSK, and neuroradiology, which, to be honest with you, is most of our diagnostic imaging. So anyway, so the other thing is looking at this by career stage. And so if you in this one study, you're looking at almost 30,000 radiologists. If you look at the amount of work that is being done by people at these different stages, you can see, of course, the first 30 years are very productive. And this group of people is doing a less of the total volume. But if you actually, so you have an abrupt decrease at this stage where people 40, well, that's surprising. The number of radiologists working past 30 years abruptly drops, okay? That's not that shocking. However, in this study, they found that the billed work only diminishes after 40 years, which means that the people that are still working at 35 years out are just as productive as the people that are earlier in their career. So what this sort of is saying is that a lot of people work till 30 years and they just stop working. Other people that keep working either don't have a choice or like it or whatever, but they continue to be very productive. Other kinds of practices, for example, my wife's OB practice, now she's a solo practice, but it's kind of traditional. You see people have the peak in their earnings is in their mid part of their career in the last 10 or 12 years. Their just income slowly goes down. The amount they work slowly goes down because their patient cohort gets thinner and thinner. But that doesn't happen in radiology because we're living the fire hose. The studies are there. We don't have to worry about whether someone's going to refer us a patient or not. They've already got the imaging, and what they really want is the report. And it's sitting there, that study's sitting there in front of you along with 100 others. So if you're working full-time, you're working full-time in this field, and there are very few models that allow you to sort of say, well, I'm just going to cut back. I had someone in my office this week who sort of said, I've been here 30 years, and I really think I shouldn't have to take call anymore. And the short answer is, well, if I said that, then we'd have a lot of people across the system that would stop taking call, which would then cause the people that are taking call to do call more frequently, which would create great dissatisfaction. And I would imagine about a third of our practice would quit. So, these are, I can understand all these things. In fact, I'm an old guy. I can really understand these things and how people feel about it. But it is it's true that if you're going to work, they're going to make you work in general. So one of the things I see is related to this is if you move a lot, you're not really bought into the practice. So it used to be you would join a practice and they'd have some committee they get you on, they get you involved in something, and pretty soon you're on the reimbursement committee, or you're on the planning committee, or you're on in a private practice, or even in an academic practice. But in general, since the consolidation has started, there's less commitment to the practice. People view themselves as employees. They don't view themselves as owners. And so there really are not the entrepreneurial opportunities that you used to have. You used to have a young person come in and say, you know, I really think we ought to do this. Let's buy a machine and we can do this. And you say, that's a great idea. And you go out and do it. Those kinds of things are much more difficult to do these days. There really usually is not any more additional compensation for initiative. In our practice, we used to have an award and actually paid some money for what we called above and beyond, like really great service. They started some new service line. Now we don't give the money, we just give the award, you know. So the resources to be able to support this kind of stuff is not the way it used to be. So young radiologists often consider themselves free agents, and we do see sort of a, well, you know, this other guy's offering me more, I think I'm gonna go work there, which I'm not blaming anybody, that's just human nature, and you have to look out for yourself and your family. But many are looking at other opportunities in the first years of practice, particularly in today's environment where it seems like every 5 minutes, actually they got my phone number now, and I'm getting continuous texts about the opportunities that are in Arkansas or somewhere, and I have stopped trying to unsubscribe because it doesn't work. So the current job market is exacerbating practice instability, because if we're desperate, we come down and prey on you, and if you're desperate, you come up and prey on us. And so how do you do that? By giving them a better deal. So we are in this sort of spiral of increasing salaries in order to trying to attract people. What we have done, and I'm sure that leaders here have tried to do as well, is that we look at trying to build an environment that has non-monetary benefits. It may be flexibility, you know, some degree of on-site versus off-site. It may be fixed hours or variable hours, depending on what the person needs. We allow people to do off shifts if it's best for their family. So some people can't come in until 9, but they work a little bit later. We try to accommodate all those things so that it can be a place where people can work and work for their career. We have people that need that time off in the morning when their children are young, but when their children are older, it turns out it'd be better if they were home later. So we just change schedules around all the time in order to try to make this happen. And reduced call can be a factor, although in our practice, we generally don't reduce call. And there are only very specific circumstances. We've done it for a few people, but it really related to true family hardship and FMLA kinds of issues that they were trying to deal with. Since COVID, at least in the last few years, senior radiologists were leaving more frequently. This is less of an issue than younger physicians. So, I mean, basically, if you have someone come in and they're 68 years old, they say, you know, I said, I'm tired, I'm going to quit. And you sort of say, well, I anticipated that would happen. Maybe not this year, maybe it would be next year. You hope they don't all come in the same year, but it's something you can anticipate. But when my, you know, new abdominal imaging ace comes in after 3 years and says, yeah, I got a better job, I'm leaving, that, you know, that's something that's tough to replace. And so this is where we are, and it is a tough market. So, of course, our health system decides, well, we're going to fix this problem. So what they did was they imposed restrictive covenants on people so that basically, you know, if the group across town wants to hire you, they can't. Now, they don't realize that, you know, my people probably wouldn't mind moving to Charlottesville, at least for a couple of years, and then they'll leave and come back. So, I mean, it is a national market. So, but anyway, these are restrictive covenants, and they now enforce them at the corporate level. So, for example, we had restrictive covenants, but I could make a judgment. Like, if someone would have some hardship, and I felt, you know what, they really, you know, that's fine. Just go ahead and do that job. It's fine. And I would just ignore the restrictive covenant. Can't do that anymore. The system basically monitors this pretty closely. But the trouble is that anybody in this room that's a diagnostic radiologist, even the IRs, you can go out and get a teleradiology job tomorrow. So the restrictive covenant means essentially nothing. We've tried to mention that to them, but what are you going to do? They really hate it when somebody goes across town and starts to compete with them, although most body imagers are not competing for work from other sites. It just doesn't work that way. Maybe interventionalists, but maybe breast imagers, but anyway. So the question we're grappling with right now is, do we offer special incentives or special compensation for people that are willing to come on site? Now, everyone in my practice has to work on site. We do hybrid for most diagnostic radiologists, like a day a week at home. They all have an academic day, so but we'd like them on site, say 3 days a week. The question is whether we're at the threshold where we have to hire totally remote people. And then if people are totally remote, well, just because they live in, you know, Iowa and they're totally remote, the person that lives here says, well, wait a minute, they're doing the same work as me. Why can't I go home and be totally remote? And so that's a problem. So we're grappling with this and trying to determine, well, what should we do? Right now, we have no fully remote people, except in really very limited circumstances. Mostly people that were in our practice for 15, 20 years, and they wanted to retire and move, but they were willing to stay on and work remotely, which we need. So we're looking at this saying, all right, so we pay people more to work on site and less. And if you think about it in terms of fairness, it makes a lot of sense to pay remote people less. The trouble is the remote market is totally fluid. So it really is driven by what the market will bear. And so if I say to you, I'm going to pay you less, then well, the guy down the street will pay me the same. So I'm just going to go do that. So I've said this many times over the years, interventionalists and breast imagers have a key role in on-site practice, and they actually become a little bit of the glue that keeps at least small and mid-sized practices in the hospital. Now, in my practice, we're going to be in the hospital regardless, but they are the face of radiology in many places. And we have hospitals in which we either have a breast imager in an outpatient center, and we have an IR working in there, and we have nobody else in the department. The problem is that they've got a fluoro in room 2, we got a barium swallow, and there's nothing that is more demoralizing to an interventional radiologist than going to do a barium swallow. We don't do that at Georgetown. And we've had a few people that are willing to do that in parts of our practice, but it's a real problem. So we're actually looking at radiology assistants to do the barium because the interventionalists aren't going to do it. So, and then local practice leadership is really essential, and developing leaders to be able to manage in this environment is a big deal. And so we try to encourage people that are interested in things like RLI or other kinds of opportunities for leadership training, because it is really a lot more complicated these days than it used to be. Talking about subspecialization radiology. So the percentage of radiologists that are now considered subspecialists has gone up about 6 or 8%. And the greatest changes in breast imaging, body imaging, and neuro. And it is more likely, or has been more common among women radiologists, early career radiologists, which is not shocking, and those in larger groups, which is also not that surprising. So if you look at this, this is just, you see the generalists just going downhill. And this goes from 2012 to 2017, body imaging, breast, cardiothoracic, barely a change, neuro, but in general, it's going up. It is interesting that interventional is going down. So just slightly there. It's an interesting thing. We'll talk about that in a minute. And this really is more graphic. 21% of radiologists were considered generalists back then. And now we're down to 15%. So there's a significant change over the course of time. And it is not geographically equal, but it is changing in terms of the percentage. And the dark colors are the ones that are getting a greater degree of the greatest degree of specialization. So my own take on this is that training steers, our current training model steers trainees towards specialization. There's very little incentive to maintain general skills. I would mention that our board examination currently has encouraged that as well, because you actually can examine in the areas that you've had subspecialty training. Now, for those who've been asleep for the last year, there is a new diagnostic oral examination, which is a general broad examination, which will force people to be able to keep general skills at least until the time they take that examination. So that actually is a trend now in the opposite direction, because one of the great complaints from the community was you're turning out people who can't do anything. They did an MSK fellowship and they seem to think they can't read a chest X-ray anymore. They have to do only that. And so that's been a real problem in the community, because practice, unfortunately, even in academic centers sometimes doesn't really quite work that way. Current graduates are most comfortable pursuing specialized practice, less flexible. I just said that. There is a secondary effect of a new division between the procedure capable and non-capable radiologists, or the procedure willing and the procedure unwilling radiologists. And so this is a real issue. So if you're thinking about neuro and non, with a division of neuro and non-neuro reading, managing minor procedures on call, increasing interest among breast imagers to take no call, there's all these things that are out there. And actually, it's almost become the standard that breast imagers don't take call anymore. We just went to that about a year and a half ago, which just killed me. Since many of them wanted to quote, maintain my general skills, but no, I can't take calls. So that doesn't really make a lot of logical sense. But anyway, some of them still do a day of general, but they don't do call. Not my decision. So general radiology is becoming more specialty radiology. And what does that mean? So if you think of a specialist, they define it in the study as those who do more than 50% of their work in one specialty area. Like I'm a neuroradiologist, more than 50% of my work is in neuro. A generalist is somebody who does less than 50% in a single specialty. So they, by definition, are not majority anything. They're doing more than one thing. However, many of them have a subspecialty focus area in which they spend 25%. So they're a body breast person, or they're a neuro chest person, or they're a whatever. So a multi-specialist is a generalist with 2 or more subspecialty areas. And of all these generalists that they identified in 2017, 85% met the criteria as a multi-specialist. So these are people that likely did not do a fellowship, or they may have done one fellowship, but they are practicing in 2 practice areas. And so they don't get to maybe the respect, or they aren't considered, well, that's the neuro person because they do neuro one day and then the next day they're doing breast imaging or whatever it might be. But even in our practice, we have a number of people that are actually double fellowship trained, but they do 2 things and they do them all quite well. So this is a trend of people still having special skills and being sort of pushed into that direction. So the generalist in modern practice typically has expertise in 2 or more clinical areas. They have the ability to interpret a range of modality studies, and they have a really essential role in on-call and emergency radiology, rural and small practice, military and VA, teleradiology practices. So the one thing I would say for those that are looking at jobs and you want to have the greatest opportunity open to you is having broad skills to enhance your, or broad skills do enhance your opportunities for a fellowship trained radiologist. So if you're doing neuro, just remember that there's a lot more to radiology and that you really want to be willing to practice in other areas, because one reason that people get bounced out of practices is the fact that they can't fit into the practice model. And even large groups have practice models that say you have to do this, that, and the other thing. And in my own practice, in the non-academic part of it, pretty much all of such specialists probably barely get over 50% in one area. So in neuroradiology, yeah, you'll be a little bit more than 50% in neuro, but you read everything else as well, because otherwise it's just completely impractical. So IR, so you all know that we've transitioned into a separate discipline that was recognized by the ABMS in 2012 as a distinct discipline. So CAQ, or Certificate Out of Qualifications, which was the subspecialty certificate of interventional radiology, transitioned to IR/DR certificates, which are different in that they are primary specialties. So interventional radiology is not a subspecialty of diagnostic radiology, it's a separate discipline. So the ABR has 4 disciplines, as medical physics, radiation oncology, diagnostic radiology, and interventional radiology. And our certificate is IR/DR. And diplomats are certified completely and without reservation and without restriction in both IR and DR. There's no limitation in DR practice. So this is, was basically driven by the need for better clinical training and also better procedure experience, because people were coming out of fellowships just not really practice ready. And we really felt that this was important if we were going to define ourselves and be able to compete against those who are offering services in other specialties that were overlapping with ours. So the clinical paradigm, as you know, is a clinical year, 3 years of diagnostic training and 2 years of IR training. Although in the future, it's likely that those 3 years and 2 years might blend a little bit more in order to meet the needs of the changing schedules. And the ACGME has recently sort of allowed that there can be a little bit more flexibility in when you do diagnostic and when you do interventional. So this is a study looking at the practice pattern of IR/DR certificate holders. So these are bona fide interventional radiologists in theory. And back in the day, like 2012, all of us that were involved in this were saying, yeah, most IRs are going to end up doing all IR, and that's what they're going to do. So it's interesting in that of all the RVUs that are in IR/DR, 65% are by IR/DR certificate holders, but 30% are by prior certificate holders, meaning they don't have a certificate, and many people just never converted. They never wanted to do maintenance certification. They basically said, yeah, and they're mostly senior radiologists. So of the group that have this certificate, 41% had more than a 90% effort. So that's your group here and my group and groups that are almost exclusively IR radiologists. But 36% of IRs had less than a 50% effort, meaning that they do a ton of diagnostic radiology. And that's one of the reasons why the ABR decided several months ago, and this was with stakeholder input, that IR integrated residents would have to pass both the DR and the IR oral examination because so many of them are practicing in diagnostic radiology. And there's actually people that were involved in the leadership of these programs that said, we don't want our residents to have any sort of cloud over their name, like, oh, you know, they had a different, aren't really as good at diagnostic as we are. They're going to take the same examination, therefore they should be considered equally qualified. So this is a benefit to these certificate holders. They are more likely to be in academic practice and large groups, et cetera. The interesting thing is, of those with more than or 50% of IR effort or more, 27% of these people never had an IR certificate. So what this means is people came out of residency, maybe did a different fellowship, and they're just become IRs on their own. They're sort of self-trained or their partner trained them up or whatever. So there's a lot of people out there across the country that are doing this. And if you look at the distribution, this is IR work, and this is not just IR certificate holders. Large majority of it is being done by people, you can see 90 to 100%, but a ton of this is, small things are being done by other people. So, understandably, most of the IR evaluation and management codes are by those that are over in these two quartiles, meaning that they're the most interventional oriented people because they're doing, patient consultation, et cetera. So which procedures are doing what? The blue is diagnostic radiologists. The green's other specialists, IR is red. So what are these? Fine needle aspiration with imaging, arthrocentesis, venipuncture, dialysis graft fissure, bone marrow, lumbar puncture, knee contrast abscess, arterial catheterization. So there's only 3 of these that I think are interventional procedures. So arterial catheterization, abscess drainage, which, by the way, has only recently been more or less taken over by IR, and many body imaging sections were doing those a decade ago, and some still do, and then dialysis work. But most of this, even though they are coded and considered to be procedures, are done by diagnostic radiologists. You get to more complicated, moderate complexity things, and you see the IRs are starting to grow here. But still, breast biopsy with ultrasound, well, no IRs are doing that hardly at all. But non-tunnel central catheters, lung biopsies, other kinds of things. But some of these are really procedures that really would never be done by an IR, like stereotactic breast biopsy, et cetera. But when you get to complex things, then IRs do these. And so angioplasties, tunnel catheters, port placements, again, thrombectomies for dialysis fistulas, not just fistulograms, et cetera. So it's pretty clear that even though a lot of procedures are done by diagnostic radiologists, and there's a great need for diagnostic radiologists to do it, that they're mostly minor procedures, which is one reason why the idea of diagnostic radiology procedures, meaning things that are inherent and must be mastered by diagnostic radiology residents, has become defined. And there are 10 procedures, and they're listed on the ACGME, but they also list on the website. And these are things like, thyroid biopsy, a simple biopsy, simple aspiration, but includes lumbar punctures and joint injections, et cetera. So those are all things that you would be tested on in a diagnostic radiology oral examination, would be expected to be competent in when you graduate from diagnostic residency. And again, that's in response to what has been perceived in practice, is that people graduate and they cannot do very simple procedures, and you just have to be able to do those in order to survive in a general practice. I'm almost finished. Just to talk a little bit about rural access, huge problem. There actually is a whole commission at ACR, and Alan obviously knows much more about this than I do, but rural hospitals really have a tough time in being able to provide IR services. And they have a terrible time recruiting and retaining IRs. Many of them don't want to do diagnostic radiology. Too few cases. Case mix complexity is not what they would like. I actually oversee the IR examinations, and when you were a fellow, graduating fellow, you actually had to apply to the ABR to sit for the certification examination. The newer program, you don't have to apply. But I had to review all the applications. So I would look at these applications and you would see people that came from an academic or what I knew to be a large hospital, and you see the entire range of IR. They're doing, chemoembolization, they're doing this, they're doing that. So they have to submit their list of procedures that they're doing in practice, and they have to have at least 200 procedures in the interval since they got done with training. And many of them have 500, 1,000, 2,000. However, you can tell there is really a division. There are people that maybe did 2,000 procedures, but 1,500 of them are paras and thoras. And they might have 300 biopsies, and they might have, a few aspirations and almost nothing else. So these are board certified interventional radiologists, or they're board eligible interventional radiologists, but their practice is totally skewed in that direction. So there's huge variability in what people end up doing in practice, and that really depends upon the kind of job you take and the case mix, et cetera. So, and part of it is rural practice, in which you might have a lot of people that you're doing paras on, but you may not have very many of anything else. Teresa Caridi, who is one of my former partners at University of Alabama, Birmingham now, she just did this study, which was actually kind of interesting. So you're looking at women with symptomatic fibroids per the zip codes, and you can see the numbers. And so women with fibroids, the darker colors are where they're concentrated, and you can see that really high penetration within Alabama. These are, first of all, the total number of UFE procedures in the entire state of Alabama during the interval of this study was 185. And there are only 5 of 16 regions that offered it. And 94% of the procedures were performed in two regions, here and here. And I think this one is UAB. I can't quite read, but so UAB did a large majority of these. So what does this say? It says that if you're in a rural setting, your access, the likelihood of being referred for some of these interventional procedures is much lower, and access is really an issue. And so it's really hard to attract people to that kind of a practice because it's just very difficult to build practice sometimes. So I would just summarize by saying, obviously, radiology practice is rapidly changing. Lots of new practice models that are happening. It seems like every week you hear about something new and interesting. I didn't even get into the entire idea of strategic radiology, which is essentially a collaboration of radiology practices, which has got, 2,000 radiologists now associated with it. Regardless of business model, I think leaders like us, we need to recognize the drivers of professional satisfaction, and we need to work to make the practice positive for radiologists. It's not just money. You have to go to work and have a sense of purpose. You have to enjoy the people you work with. You have an environment that meets your needs. That includes being somewhat flexible to meet your family needs as well. And I think that in an environment, if this is for everyone in practice, an environment that continuously emphasizes productivity and economics, we need to remember that our mission is the care of patients, and that's whether it's through imaging evaluation or intervention. So, with all this sort of maelstrom of things that are going on, it's easy to kind of get sucked into thinking about that all the time. But the beauty of what we do is every single time you look at a study or do a procedure, you can help one person and you can make it better. So you have to keep that in front of you as you go through your career, because there'll be times when you get a little discouraged with how things are going. So as I like to say to people, you can always do good in medicine. There are a lot of things you have to put up with, but just keep that in mind. So with that, thank you. And I'd be happy to take any questions you might have.
Any questions for Dr. Spies? A complicated topic. When I go to AMA meetings, and I realize that when it comes to consolidation and involvement of employment models of radiology, got over probably in the last 3 years, more than 50% of radiologists are now employed. And Colin and I and Jim went to private practice and Chris, there was academic and private practice. Right now, there's many different models. There's academic, independent private practice, there's multi-specialty organizations, there's private equity. Now there's this whole new group that we call 1099. Basically, they contract out with 10 different hospitals, they're their own business, and they just read. Really, frankly, no allegiance to anybody. If I read, I don't care, hard to build a department or a group or something. Right now, there's so much work to be done. Thing that when I go to AMA, radiologists and surgeons are probably still the highest percentage of specialists. Gastroenterologists, cardiologists, you go down the list, family medicine, emergency medicine. More of them are important. Very interesting dynamic.
Yeah, I would just say, not to put a plug in for the kind of practices that we have, but we are a little bit like a port in a storm. I mean, there are so many benefits to being in a practice like this. First of all, you're all in a room together. You're all going to have lunch together tomorrow. You're all going to see each other. You're going to be able to tell each other stories and jokes and whatever else. That's totally different than being a 1099 or whatever, even just working for one teleradiology company where you sit in your basement and you just read. And there's a little meter on there which tells you how many RVUs you have, and essentially you can do a little multiplier as how much you're going to get paid. And it really is a soulless undertaking in my mind. I just don't know how people can do it. And I'm not criticizing because I know people, for family reasons or other kinds of things, you have to pick the practice model that's going to work for them. But when people ask my advice, the first thing I say is don't start practice in a teleradiology remote practice. If you can avoid it, it's good for your soul and it's good for your training and your own experience to try to work in some kind of a collaborative environment. You also can leave academics easily if you decide that's what you want to do down the road. It's also, we have people, I don't know if you have the same problem. We have people that work for a teleradiology company and they want to join a group like ours. And then we look and we say, oh, look, you have hospital privileges in 300 hospitals. Do you have any idea how much work it is to try to do primary source verification from each of those hospitals in order to meet Joint Commission's requirements in order to hire them? So we generally don't hire them because it's just too much work. So.
Any questions for Jim?
I don't know relates to this, but radiology has always been so, I think, famous for really being focused on teaching, and radiologists, I think, as much as any specialty in medicine, we're just really into it. But golly, now it seems like we have to find some alternative way to fund it. It seems like that. How's that going to go?
I don't know if that's me or. Yeah, maybe that one. Yeah, it's interesting. I was able to negotiate with my group. So we got a 10% cut in RVU requirements for the academic group. So we have a little bit of a bonus that's productivity based. And we basically said, it's not right to judge this entire group at the same level because we have to teach. We'll have to, we get to, but it takes time. And if you're going to do it, it really takes time. So we were able to convince them that our target's 90%, theirs is 100. And so we actually got some benefit from that. And actually with those targets, it actually allows us some time. Right now, though, if we were perfectly staffed, we actually, I think, can reasonably do a good job of workstation teaching, which is really what we're talking about. But being short, it's tough. And that is a source of strain. Nearly everybody that talks to me at their annual review says, I came here to teach and it's just getting tougher and tougher. And that's true. So my role is to try to figure out, all right, how can we get to be staffed back to the way we used to be so that people are looking at those volumes? And I'm not sure we're going to get there, but we certainly can move in that direction. But there isn't an easy answer to it. If there were more radiologists out there, there definitely would be. So,
well, it's a little after 6. Ty, are there any questions online? Okay. And I want to advance this. How do you? There we go.
Yeah.
So I want to thank Jim for being our 17th annual Tegtmeyer lecture. We want to present him a print here, and it'll be a print of the Haley comet over the rotunda from 1987. It's nice and wrapped up in here. You can leave it wrapped up, but that's what it looks like. So that when you take it home, it'll survive the drive home to DC. But I want to thank Jim very much for being here and being the Tegtmeyer lecture. Don't forget, Fritz, your boss said, everybody hang, take a picture with Dr. Spies in the back of Karen. Karen's been waiting this whole time. Take your.
I'm good.
Okay, yeah, so thank you very much. Thank you.